patient in the center. So you have rheumatoid arthritis, and that is your condition that I'm dealing with, but the patient is placed in the middle, and all the other issues are around that patient that actually, for ideal treatment, ideal outcomes, you need to deal with all of this. Now, how complicated is this in our current medical system? Do I truly have the time to go through all of these issues if I want to do a good job with my patient? Very, very challenging. If I have no support from family docs, no support from an internist, no communication with, let's say, the diabetic doctor, and it's really a challenge, okay? And you could probably start to get the picture that I might be able to improve the arthritis, but I need to be sure that all these other things are being dealt with. Challenging. What do we know about multimorbidity? We know that patients with, let's just take rheumatoid arthritis for the moment. If you have multimorbidities, in other words, all those other medical things going on, what happens to a patient like that? Well, we know that there's a reduced quality of life overall. So in other words, if you just took a rheumatoid patient who has nothing else and a rheumatoid patient with all these multimorbidities, the one with the multimorbidities is going to have poor quality of life, higher risk of mortality. I know that sounds scary, but it's true. Reduced socioeconomic status. Will end up for sure with polypharmacy, meaning multiple, like those are the patients who come in with a bag of drugs. When they say, what pills are you on? You know, they come in with a shopping bag. Higher rates of adverse drug events, and greater health services utilization. And I think these are the practical steps. I think we have to raise awareness about this, and we need advocacy. We even need you guys as patients to actually sometimes raise some awareness for your doctor, because sometimes you're a little intimidated. You're coming to, let's say, the arthritis doctor. I better not talk about anything except my arthritis. But if you're struggling with mental health issue, someone's got to know. Maybe there's a resource to help you with this. If you're living with chronic pain, you're suffering, maybe you've got some deformities, maybe you've got some other difficulties for whatever reason, and you're struggling, you need some help. And if you have no one to talk to, I think it's legitimate to bring it up with your rheumatologist, if at least somebody can try and direct you. Now, it's difficult for us to take on the role of treating blood pressure and cholesterol and all these things. It is challenging, I have to say, but at least maybe we can help direct you if we're aware of some issues that you may have. So we need to have really an individualized kind of management plan. So I wanted to make a word, because one of the most common comorbidities in inflammatory conditions, so autoimmune inflammatory conditions that we're talking about, one of the main things that we worry about is heart disease. Okay, we know that patients who have active inflammation in their system, and we can measure that with a blood test called the CRP, that's usually what we measure. We used to measure a test, some of you may remember more, called the sedimentation rate, or the ESR. That is a measure of inflammation as well, not as good a test, but we measure the CRP. So people with high CRPs have a higher risk of heart disease long term. So it's not a good thing to be walking around with inflammation in you all the time. It leads to a higher risk of heart disease. So if we look at the population at large, heart disease is a big problem in the population, but in rheumatoid arthritis and other inflammatory forms of arthritis, it really is quite a serious issue. And it's a little bit different, because in inflammatory conditions, the heart disease is driven by inflammation. In non-inflammatory, so general population who might have a risk for heart disease, the other risk factors are very important. Family history, are you a smoker, do you have diabetes, things like that, very important. But if you add something like rheumatoid arthritis into the pot, it multiplies your risk by 1.5. Okay, so there are calculations you can do to determine what's your risk of heart disease. There are calculations based on your profile that we can do. And if you have rheumatoid or other inflammatory arthritis, you actually multiply it by 1.5, so it's actually higher risk. So it needs to be paid attention to. And this was a few years ago in Time magazine, talking about how inflammation drives heart disease. So what do we need to do? General assessment. And I must say, I'm guilty of not doing this on every visit either, and it's just a question of resources. But check your patient's blood pressure. Make sure we're getting their cholesterol profile, their blood sugar profile, assess whether they're smoking. BMI is body mass index, so are you overweight? Maybe you need to work on your weight control. And then using that risk factor calculation, as I said, the score is a multiplication factor of 1.5. So I think we need to pay attention to whether patients are at risk for heart disease and have them treated for that, not just their arthritis. Rheumatoid patients have an increased risk of infection. We know this. That's also driven partly by inflammation and other factors, drugs. Patients are on cortisone very often, or other immune suppressive or immune modulating drugs that put them at risk for having infections. We're living in a COVID world. This was a huge fear for our patients on all of these drugs. How do we handle this with COVID? How do we handle their vaccinations? How can we reduce the risk of infection and keep our patients out of trouble? So infection risk, another thing that's a little bit higher in our patient population. And some of the medications can put you at risk as well, like steroids. Of course, cigarette smokers, interestingly, have a higher risk of rheumatoid arthritis, and they also get pulmonary problems. So if you think about the risk of infections, you're magnifying this tremendously by being a smoker. So let's get into a little bit of some of the things I wanted to address today also that I'm sure you guys have all had questions about. So, is there a care gap? Are we missing something here in how we treat? Getting back to my, here's a pill, okay, kind of opening statement. So we have amazing new medications on the market now for inflammatory arthritis. We never had these before. I mean, I've been in practice now, 25 plus years, and we started with the biologic, those fancy newfangled drugs in the very early 2000s. I was involved in clinical trials that turned patients' lives around, actually. So really, in the last 20 years, there's been an explosion of new drugs. It's great. But the outcomes are better. We have many treatment options. And now we start talking now not just about, here's a pill to make you feel a little better. We want patients to go into remission. We borrowed a word from the oncologist, and we talk about remission now. Remission means disease-free. It's a whole other topic in and of itself. It's debatable what remission really means, but that's our goal. We want you to feel like, I don't even have arthritis. I feel good. Doesn't even bother me. That's remission. What we want to hear from our patients. Not always achievable. And so here's the true story, is that despite all our new drugs, the rates of remission are only about 30 to 35%. So that leaves most of the patients who never quite get to remission. So there is a gap. We're not quite there yet in even the treatments that we have. A lot of the medications patients don't like. They have side effects and so on, and we know that. And so what do we hear from you guys out there? These drugs are scary. We sort of say, I think you needed one of these newfangled drugs and stuff, but what does it mean to say to somebody, we're going to give you a drug that suppresses your immune system? I mean, how happy are you with that? That sounds kind of frightening. And some of the drugs are used in chemotherapy. Also, like, just a second, doc, like, I don't have cancer, I have arthritis, like, what are you prescribing for me exactly? So patients are worried about this. They really need the time to understand what we're doing. And so patients will say to me, listen, I don't like I'm not a drug person. I don't want meds. I hear this all the time. So what else can we offer people? People ask me, is there a diet for arthritis? Are there any natural products? Is there something I can do besides just the pills that you guys like to give us? And the bottom line, I think, is this, and I think that, unfortunately, I don't think all physicians are getting this, but I think it's true that our patients want to be heard. I think they want to be validated. Patients have questions. They have concerns that are legitimate. And I think we have a responsibility to listen to them and to try and guide them, for them to be satisfied that they're getting the best treatment that they can. And when we come out, every couple of years there's these new international guidelines, new guidelines for how you treat rheumatoid arthritis or psoriatic arthritis or whatever it might be. Every single new guideline starts with an overarching principle called shared decision making, which means that we have a responsibility to sit down with our patient and say, let's work on this together. Let's try and figure out what you're comfortable with vis-a-vis medications, other options that we may have, and let's come to terms that, let's meet somewhere where we're both comfortable with the approach that we're taking. That's shared decision making. And I think, for me in my practice, it always works better for me when I have a patient when I'm aligned with my patient, you know, when we're sort of on the same page and we're comfortable with what we're doing, because there's different ways to treat things. So let's talk a little bit about diet. Very controversial thing. I see Jean book on the desk, you know, that I was involved in. I know Kim Ari, dietitian, has spoken here before. So Kim and I kind of did with now the second edition of the book, and about diet and arthritis. It's a very complicated issue, you know. I'm very open-minded to it, but I do want to say a few principles. You know, there really isn't a one-size-fits-all diet for arthritis. I think that, you know, the internet and so they feed on patients and prey on patients' fears, you know, with this. It's like, you know, you're going to hear these things about, you know, cure your arthritis by doing this or that. It's not true. It's not true. I think diet has a role to play, and I think you can help yourself, and there are some sensible things that we can say. There's many books that have been written, a lot of misinformation on the internet, but there's a few sort of do's and don'ts and a few good sources, like the American College, the European Union for Arthritis, the Canadian Rheumatology Arthritis Society, and so on. And the reason it's difficult is, you know, when you do a drug study, you probably heard the term clinical trial, a double-blind placebo-controlled trial, okay, right? Those are the most effective, most credible studies when we're launching a new drug. That means that the patient doesn't know what they're taking, the doctor doesn't know what they're taking, double-blind, okay? And it's versus a placebo. Well, how do you do that with a diet? Okay, you really can't. You know, and so there's stuff out there like, you know, we have a proven diet for arthritis. Well, you know, I'm sorry, it's very difficult to say, you know, follow this diet and let's see how you are in 3 months. And then the patient will say, no, I'm feeling way better on that diet. I'll say, that's great. I find that patients who want to take a diet approach or a natural supplement approach, it's usually at a time in their life where they made a decision, I want to take control, okay? I want to make some changes, I'm ready to do it. I'm going to alter my diet. So patients come in and say, that diet's really good. I'll say, by the way, have you lost any weight? Oh yeah, I've lost 25 pounds. Oh, are you exercising? Yeah, I'm going to the gym now 3 times a week. I have a trainer, but that diet is great. Yeah. You know, I hear this a lot. I'm not making fun of it or putting it down. It's great. But there's usually other things that are going on in someone's life because they've made that decision to take control of things, diet being one of them. Very often it comes with exercise and weight control. So what's actually helping? Very difficult to study that. Okay, so you can just be careful when you read about these things that sound like the greatest things since sliced bread. Diets are very hard to control. So you've seen all of these things, all these diet books are out there. I can tell you that this is the one that Kim and I did, and the second edition is actually on the table there. You know, when the publisher came, I'd never done anything like this before. When the publisher came and asked about this, I said, listen, if you want me to write something that says, you know, the 90-day arthritis cure, or I said, I'm not your guy. Like, I'm not doing it, because I just don't believe in it. I don't believe in preying on people like this. And if you want us to do something, it's going to just be even-handed, sensible, better eating habits, but I'm not going to tell people that follow this, buy this book, and you're going to be cured. No way, because I don't believe it, okay? So again, my message is there's something there, but it's not the only thing. So there are some things in foods that can promote inflammation, so I call them pro-inflammatory. And one of the most important things are called AGEs, which are advanced glycation end products. You can, if you eat foods that have AGEs in them, it increases something called oxidative stress and inflammation. And this is found a lot in animal products. So a lot of, you know, red meat and animal products, that's why we sort of say, you know, moderation, not too much because of AGEs that are in those foods. And you also can increase, so it's not just what you eat, but it's actually how you prepare your food. So AGEs will increase by grilling, barbecuing, frying. Those are not good ways to prepare your meats on top of it all, if you're looking to have an anti-inflammatory kind of diet. So your actual preparation of your food matters too. Other pro-inflammatory foods, sugary snacks, white bread, pasta, pastries. It doesn't mean never touch a thing ever again. Be sensible, you know. Look at the profile of your diet, and maybe you need to just have a little bit less. if you find that this is one of your weaknesses. Vegetable oils, which are high in omega-6, are not good. Omega-6 is pro-inflammatory. Omega-3 is anti-inflammatory, where you're going to find much more in olive oil. So if you're going to cook with oils, olive oil is better. What other foods? People read about this all the time. Nightshades. You've heard about this class of vegetables called nightshades. So nightshades in the North American diet. Tomatoes, potatoes, eggplant, peppers. They contain something called solanine, which has been attributed to increasing inflammation. So again, if this is really something that you want to look at, maybe reduce a little bit of that. Dairy is very controversial. This is in most arthritis books, especially the ones that say the arthritis cured. They tell you to eliminate dairy. There is no evidence scientifically that dairy causes inflammation and worsens your arthritis. I'm just telling you that. There are some studies, in fact, that show the opposite. Okay, that's good for you. And now, some people could be sensitive. You can have an allergy or sensitive to, say, dairy products. Okay, you need to avoid. But actual dairy, complete elimination of dairy, I think is a bad move for people, because dairy has good fats, dairy has calcium, which is good for your bones, and osteoporosis is a big problem for arthritis patients as we age. So there's good things in dairy too. So don't fall into the trap of just saying, oh, I was told to eliminate dairy completely. I think it's a mistake. Gluten, there are people who are gluten sensitive. If you have celiac disease, you need to avoid gluten. And then some people just have gluten sensitivity. They know that when they eat certain high gluten foods, they know they react. Okay, makes sense. Avoid it. But generally, if you're not one of those, you don't have celiac, and you don't seem to react, there's probably no role in avoiding gluten at all. Anti-inflammatory foods, I would say generally, the best thing to do is to follow a Mediterranean-style diet. It's the most sensible thing to follow. It's not a crazy fad diet. It's very sensible. It's more fish, less red meat, more whole grains, nuts, fruits, vegetables, normal kind of healthy eating, okay? And I think it's the most sustainable thing for people to follow if you're interested in having a little bit of a diet that might help for your inflammation. So fatty fish in particular are better, so things like salmon. And there's a lot of information now. One of the things that's quite interesting, actually, I've been trying to follow the sort of data on this, is curcumin, which is found in turmeric. You can cook with more turmeric. There is some science behind this that it looks like it has an anti-inflammatory effect. So a lot of people, it's a very popular thing to take turmeric. And of course, we mentioned olive oil before. I just want to show you that there is a little bit of studies and data behind some of this with diet. So there was a diet here looking at rheumatoid arthritis patients who were given only 2 weeks of a very strict anti-inflammatory diet, which was Mediterranean style. They called it the AWISH diet. So for 2 weeks, these patients agreed to enter into a clinical study, but it was very rigidly done. Okay, they weren't just left on their own. They were monitored daily to look at their food intake, and they had to bring in diaries and so on. Only 2 weeks, because it's hard to monitor it for much longer in people. But at 2 weeks, improved fatigue, and was associated with changes in the gut microbiome, which was really interesting. And they reduced a little bit the sedimentation rate, so there actually was evidence that it was anti-inflammatory. And then there was another study, look at this, I thought this was interesting too, a study of eating fresh fish twice a week. Just adding fish to the diet twice a week reduced inflammation in rheumatoid arthritis patients based on approved disease activity measures, something called the DAS-CRP, which is a calculation you do. And then the other one that's really fascinating is intermittent fasting. You've all heard of intermittent fasting, it's really popular. And actually, there is some interesting benefit for reducing inflammation. This goes back years, even I think when I was a resident at the time. Somebody did a study about fasting 2 days of every month. This was the first study I ever read about rheumatoid arthritis and fasting. And just by doing that, patients reported improved outcomes. And now with intermittent fasting and reducing your consumption, there has been some data that show that there's reduced inflammation. So that's another thing that's a little bit interesting if you find it's practical for you. There may be some benefits. So what kind of sensible advice can we give? Okay, so to sum it up a little bit, the Mediterranean style diet I think is sensible. limiting processed foods, sugary type snacks, too much red meat. Try and have leaner meat if you can. Cook with olive oil. Avoid that high heat cooking, which increases those ages in the food, particularly the meats that you're cooking. Consider reducing nightshades, maybe gluten, and maybe dairy if you know that you're sensitive. I have had patients come in and tell me that their joints feel more swollen and achy after they eat gluten. Well, all I can say is reduce gluten. You know, like it's common sense, really. Elimination diets, be very careful about that, especially dairy, because there are good things also in dairy, and you need to replace it somehow. You need to get your calcium with your kale, almonds, other areas where you can get some of the nutrients that you'd be missing with dairy. And then let's get into a little bit of supplements. This is the most difficult thing I find. Patients come in and they heard of something, and there's stuff all over the internet, and like, what do we do with this? Here, the vitamin cure. When you see a book like this or something, the word cure in there, be very wary. Just be very wary. I know it feeds on you. It's like everyone wants to have hope, and everyone wants to grab onto something, and I get it, but it's so unlikely. It's just so unlikely. Look at this. This natural drink will cure rheumatoid arthritis. I mean, come on. Seriously? Like, here, look at this, the carrot cure, okay? I mean, there's so many things out there. I like this one. This is a curcumin suppository, okay? All right, so, there's so many things. This one I've actually had patients come and tell me this is the gin and raisin cure. You know how this one works? The gin and raisin cure. So you're supposed to fill, what you do is you take like a bottle of gin, okay? Whatever it is, they come in 750, cc's you buy at the sack. And you're supposed to put in, I think it's 12 raisins, okay? And every day, you're supposed to start your day with 2 ounces of gin, okay?
2 ounces?
And that's supposed to be arthritis. And I've had patients tell me, I'm feeling better since I've had gin in the morning.
Happier too.
So I'm wondering, what's really happening. But, this stuff's out there. It's all out there, so, you have to be wary. So let's talk a little bit about supplements. And I'm just putting this up here. If it sounds too good to be true, I mean, you've got to be smart about it. I've seen so many supplements advertised, cure for arthritis, and by the way, it helps your depression, and it cures your hemorrhoids, and read these things, okay? I mean, it's really unbelievable, and when you start hearing those crazy things like those claims, you know that this is something to stay away from. All right, a big ad taken out in a newspaper or whatever. Be very careful about that. Now, there's some stuff that's interesting. All right, there's again, most of you have probably heard about glucosamine and chondroitin. Glucosamine and chondroitin are supposed to replace some of the lost cartilage that happens in arthritis. And for osteoarthritis, nothing for rheumatoid, but in osteoarthritis, there's some, I would say, weak data that suggests that it might be beneficial in some patients. In fact, in Europe, that's called the EULAR guidelines, they actually recommend adding chondroitin if you have osteoarthritis in your hands. It's actually a recommendation. So, I'll tell patients to try it. I usually tell patients 3 months. If you want to go for natural products, try it for 3 months and make a judgment on what you think. Don't throw your money away. You're still taking pills. Not really much in the way of side effects, but they could interact with some pills, particularly blood thinners. Be a little careful. You should tell your doctor that you're taking these things. I would like to know if my patients are on these supplements. I'm not against it. There's some logic, but don't, how do you know it's working and how long? Are you going to take it forever? These things are expensive. So I think a good rule of thumb is a 3-month trial and see how you feel. And then make a decision if you think it's really worth continuing with. Turmeric we made a word about. Vitamin D has been a very hot topic in the last few years actually, in that it may be linked to autoimmune problems, and vitamin D supplementation has been talked about a lot. So there was a couple of studies, very recent, in 2021 at one of our national meetings called the American College of Rheumatology. We saw that there was a paper that said that vitamin D deficiency was associated with increased inflammation in something called spondyloarthritis, which is an inflammatory arthritis. And then also that if you supplemented patients with vitamin D and fatty acids, you might reduce autoimmune disease by up to about 30%. That was pretty interesting. My take on it is, if you're vitamin D deficient, definitely you should be on vitamin D. If your vitamin D levels are completely normal, there's zero evidence that taking more vitamin D helps you, all right? So that's, I think, an important point. Vitamin D is the sunshine vitamin, so you get it from the sun. And it is in some fortified foods like milk and stuff in our country. But in Canada, where we sometimes don't get much sunlight, if you measure vitamin D, it's very interesting. If you measure vitamin D levels on the same person in the winter and then in the middle of the summer, you'll see low vitamin D in the winter and normal vitamin D in the summer. We see this all the time. And that's just because of the climate. We live in this northern climate without people getting outdoors and without getting the sunlight. So vitamin D deficiency, I think, is important to address. It also is helpful for osteoporosis. So it's something to think about. I think it's an easy thing. And I think that pretty much all women post-menopause and all men, older men, let's say over the age of 75 for sure, should probably take a vitamin supplement. You know, at least in the winter time, vitamin D, about 1,000 milligrams a day would be appropriate. Okay, we mentioned weight loss before, and there's some fascinating stuff about weight loss and osteoarthritis. And it sort of makes sense, right? If you have osteoarthritis in your hip or your knee, and you're carrying around too much weight, you would think that if you could lose a few pounds, you'd feel better, you know, and it is true. So there have been studies that have shown that as little as a 10-pound weight loss can decrease knee OA. So my goal for patients who really need to lose weight, I think that's sensible, is to try and target a 10% body weight loss, like 10%. You know, we're not all gonna be, people struggle with their weight. It's not everyone's fault. There's metabolic reasons why people are overweight. Not everyone is gonna be skinny minis. What's the word I'm thinking about? I'm trying to think of a famous actress like Mia Farrow or whatever in the old days, you know? It's not achievable for most people, but I think if you can sort of say, look, I'm gonna work on that 10%. So if you're 150 pounds, but you really could lose some weight, you know, what's 10%? It's 15 pounds. You know, that target will probably give you a better quality of life and you'll feel better. And I think it's sensible. So we know that patients who are overweight don't do as well. They don't respond as well to biologics, actually, in inflammatory arthritis. That's an interesting thing as well. So weight contributes somehow to your response to medication. That's an issue. And I want to go back to the very first point, which is just being overweight. Obesity itself, fat itself, promotes inflammation. It's a very interesting thing. Fat cells promote inflammation in the body. And people who have obesity problems, and they have higher CRP levels. That's the measure of inflammation in their blood. So if we take 10 people who are obese, meet the criteria for obesity, and 10 normal weight people, the 10 who are overweight are gonna have higher CRP levels than the normal weight. Higher CRP, higher inflammation. Higher inflammation, more challenging for all the reasons that we've been talking about. So, exercise impact, and I can't impress upon you enough how important the addition of exercise is to your arthritis treatment, regardless of the kind of arthritis. So this was an analysis of 37 different trials, and they found that people who were able to maintain physical activity, less pain, less fatigue, improved mental and activity performance. IA stands for inflammatory arthritis. There was a trial called the IDEA trial, which combined exercise plus diet, and they found that that was better than only diet or only exercise in reducing pain and CRP. So just to the point that I said before about people who go, when you combine these things together, you do even better. So exercise of any type really, you know, is so important. You know, not everyone's gonna be able to jog and go for a run, but people could walk, many. People can go on an exercise bike, many could. There's ways of doing things, there's ways of getting help with trainers and so on. Just a few more things. Smoking, huge problem. For some reason, we know that rheumatoid arthritis patients tend to smoke more than the general population. I'm actually not positive why that is, but it's a known thing. Smoking itself does something to proteins in your blood that are called citrulline proteins, and it alters them. And that increases your risk of getting rheumatoid arthritis to begin with. So smokers get RA more often. And if you're a smoker and you have RA, you're more difficult to treat. Just like obesity and osteoarthritis, more difficult to treat, smokers don't respond to medications as well. And it's a big challenge. So smoking cessation has to become part of the treatment. And I think, again, we really missed the boat there. I want to follow up on this one section, and then I'll leave a little time for questions. The mental health issue. I think this is maybe the biggest issue of all the things we've been talking about today. And mental health resources in our current Medicare system are really deficient. I don't know if any of you have had to try to access mental health services. It's really a challenge how to navigate the system. But mental health issues are very common in arthritis patients. I'm really competing with this music fest here. So just to tell you, I just want to make a few points. Depression itself is very common in inflammatory forms of arthritis. Most estimates are that it's as high as 20% of patients have overt depression who are suffering from inflammatory arthritis. And depression, like smoking, like obesity, reduces your chance of responding to treatment. So it's a very serious issue if you're trying to treat somebody. We have arthritis patients, we're treating them, it's like, I think the drugs are pretty good that I picked. How come they're not getting better? And then we're not diving into those other issues. Oh, you're still smoking. We need to address that. Oh, you're really down in the dumps and you're suffering from depression. Maybe that's why they're not responding. And we're not addressing those questions. We don't have the time or the resources, and we're missing things. So depression and anxiety reduce the chance of remission in rheumatoid arthritis. That's in one study. And the other thing that there's a lot of research on now, I don't have that much to tell you about it, but it's a bit of a chicken and egg thing. So you could sort of say, well, I have arthritis from whatever age, I've been suffering for so long, I've got some joint deformities, it's been really challenging, I'm in pain all the time, I'm not sleeping well. Like, what do you think? Of course I'm depressed, right? But there's something very fascinating. It seems that inflammation itself causes depression. So, and there are some theories that depression is an inflammatory condition. So you see where there's a two-edged thing. There may be reasons why people are struggling with mental health, but actually if we're not treating their inflammation adequately, that might be driving their depression. So it's a two-sided thing that needs to be, we need to pay attention to. So there's things like mindfulness-based stress reduction. Have you ever had a mindfulness person here? You have, I think. I remember seeing that on the list. That's an interesting thing that's been actually quite studied. Mindfulness training to sort of help with the mental health issues in arthritis patients. And so we need that sort of multidisciplinary approach, including mental health professionals, big challenge. So RA and depression, major depressive episode, very commonly, we said any estimates in different studies, anywhere between 32 and 42%, that's 13 and 42, that's high. So I rounded it off to probably somewhere in the middle is probably the truth, around 20. And depression is 2 to 4 times higher in rheumatoid arthritis than in the general population. So it's a pretty big issue. It's not a small thing. So I mentioned systemic inflammation may be associated with or even cause depression. CRPs are often higher in people with depression. So if you take just depression, no rheumatoid arthritis, and you measure their inflammation levels, they're actually higher. So that led to the thinking that maybe depression is actually being driven by inflammation. So challenging to figure it all out. So it's a multifactorial problem, RA depression. It's the RA disease, inflammation may be driving it, socioeconomic issues, and so on. And so we know very little about, all the studies are done in women. We know very little about men with depression. And I think that's sort of a gender thing. I think women tend to be a little more forthcoming and open and bring out these issues more than men do. Men tend to be a little more closed. So I think it's hard to get the estimate of what's actually going on in men. But I think it's a key concern, because I think men might be misdiagnosed, underdiagnosed, and not getting a fair shake sometimes. And so, we need to look at issues about what's going on in family, employment, and so on. So to finish up, here are my messages for today. Comorbidities, lifestyle choices really need to be considered if we want to treat the whole patient and not just look at a person like you have arthritis and nothing else. Many patients really want this advice. They want alternate treatment options besides just giving them drugs. Shared decision-making is a very important principle, and I think the best outcomes are when we can have an open relationship with our patients and talk things out. Ideally, a multidisciplinary approach with healthcare professionals. If we had access to cardiologists, mental health care professionals, dietitians, all these things, I think we would be seeing better outcomes overall. And again, remains a challenge in our medical system. And so what can we recommend? Listen to our patients, be open-minded. This is meant for also doctors that I've spoken to, by the way. Stick to the science, stay open-minded, be careful about Dr. Google. Patients come in and they want to know things. It's legitimate to allow them to speak and to talk it out, but make sure you know where to sort of pull the reins in a little bit. Sensible diets, exercise and weight loss, very important. Stop smoking. Be aware of and try and address the mental health impact on disease, and try and get patients to have good resources. Like there's a website called LifeMD developed by a colleague in gastroenterology actually out west, who I've been in touch with. It's really a gastroenterology website, but she's trying to develop it for arthritis, and I've been a little bit involved with her on that. It's kind of an interesting one. Room Info, there's a lot of information. That was developed by a colleague in London, Ontario. And then credible arthritis websites, the Arthritis Society, ACR, CRA, all the things, we've mentioned a few of them. And so I'd like to finish again with William Osler, Sir William Osler, and what he said is, the good physician treats the disease. The great physician treats the patient who has the disease. And I think I'd like to end that, and questions. Thanks for your attention.